to all our Athero listeners. I am Elena Rodriguez Sanchez from the David Geffen School of Medicine at UCLA, and I want to welcome you to another exciting episode, this time with a special twist. In this episode, we are diving into the brand new consensus statement from the European Atherosclerosis Society on clinical staging of metabolic disorders, which was published in the European Heart Journal. What makes this even more special is that two of the EAS Young Fellows, Pelin Golforush and Ralph Achea, were involved in shaping it. We will start by hearing their conversation with the lead author of the statement, offering insights straight from the source. And don't miss the final segment, where we will go behind the scenes with Pelin and Ralph to explore what the consensus process was really like from a young fellow's perspective. It is an exciting peek into how major scientific work comes together, so if you're curious, stay with us.
Thank you for the introduction. I'm Ralph Achea. I'm currently a senior research fellow based at the Center for Academic Primary Care at the University of Nottingham.
And I'm Azin Kheirkhah from the Institute of Genetic Epidemiology in Innsbruck. We are very excited to co-host this special episode and to welcome our guest, Professor Stefano Romeo, the lead author of this crucial consensus statement.
Professor Romeo, congrats again on the publication of this important paper. Thank you for joining us on Athero Talk.
All right. Thank you guys for having me. It's my pleasure to be here. Thank you for the invitation.
Thanks a lot. So let's begin by framing the core objective of the paper. This consensus introduces a new clinically intuitive staging system for systemic metabolic disorders, conditions like type 2 diabetes, steatotic liver disease, hypertension, and so on. Why is it important to view these as part of one systemic disease rather than separate comorbidities?
This is important from multiple perspectives. First, recognizing the human body as a whole rather than viewing it as a set of isolated organs is a critical reminder for physicians. From the perspective of the patients, also, this holistic view can also be deeply reassuring. Therapeutically, it reinforces a core principle. Whether we are addressing the heart, liver, or kidneys, the foundation of treatment remains the same, lifestyle intervention. This means increasing physical activity, reducing sitting time, and following a healthy diet.
That brings us to an interesting aspect of the paper, that is the treatment of inflammation. We've talked about inflammation before on Athero Talk, including with Professor Paul Kheirkhah, a co-author of this paper. This consensus paper gives inflammation the same status as hypertension or heart failure, yet does not offer staging criteria for it. Do you think we are close to considering inflammation to be a disease in its own right? And if so, what kind of criteria would we need to define or stage it?
I wouldn't fully agree with the idea that the main novelty is the elevation of inflammation to the level of hypertension or heart failure. In my view, the more impactful shift in this paper is the recognition of insulin resistance as a fundamental and measurable driver of systemic disease at the same level with traditional risk factors like hypertension. This consensus paper positions insulin resistance not just as a risk marker, but also as a causal mechanism underlying a substantial proportion of metabolic and cardiovascular burden. For these reasons, we recommend measuring fasting insulin as a practical approach to assess this trait in clinical settings. As for inflammation, the paper certainly acknowledges its presence alongside fibrosis as part of the systemic landscape. But I think the jury is still out on whether inflammation is an actionable trait for preventing atherosclerosis.
So another condition that was actually highlighted is the heart failure with preserved ejection fraction, which the paper suggests that it will soon be the dominant form of heart failure. So we were wondering, is this really a new disease trend, or has it simply been under-recognized? And that what role do sex-based differences play in this shift?
Absolutely. When it comes to diagnosis, I think it's a combination of both factors. On the one hand, FPEF has likely been under-recognized in the past. But on the other, we're now seeing a real increase in its prevalence, largely driven by the global rise in obesity, a major risk factor for HFpEF. As obesity rates continue to climb, so does the burden of this form of heart failure. Regarding sex-based differences, it's becoming increasingly clear that we have historically underestimated the burden of heart disease in women, not just HFpEF, but also atherosclerosis. Fortunately, there's now growing awareness and more efforts to improve diagnosis of cardiovascular disease in women, which is helping to correct this long-standing gap.
We'll now turn our focus from a bit of the theory to practical application, specifically how this consensus paper can help frontline clinicians or clinicians on the ground. The staging system is described as clinically intuitive. Could you explain what this means in this context and how the staging system or model differs from earlier clinical guidelines?
So the consensus is clinically intuitive because it reflects an understanding of the body as a whole rather than a collection of disconnected organs. From this perspective, the distinction between conditions like hypertension, dyslipidemia, or insulin resistance becomes secondary. What matters is their shared pathological impact. These risk factors converge on similar downstream damage. And when complications emerge, it no longer matters whether we are dealing with the heart, liver, or kidney. So the clinical intuition here lies in recognizing that organ-specific manifestations are simply different expressions of the same systemic disturbance. So this unifying view is not only pathophysiologically sound, but also aligns with how experienced clinicians naturally approach complex systemic disease. We had several prior consensus papers addressing concepts like clinical obesity and the cardiorenal syndrome, but what's new here is that for the first time, the liver is explicitly included as a target organ. This represents a shift toward a more integrated view of metabolic disease, acknowledging that the liver plays a central role alongside the heart and the kidneys.
Thank you. I would want to bring in a bit more like personal bit because my research is in primary care research. So I just want to find out for clinicians who work in primary care, how do you see this being integrated into everyday patient management? And are some aspects easier or more challenging to implement?
Yeah, I think general practitioners can use this framework as a tool to identify people at risk earlier before the end organ damage occurs. So it provides a clinically relevant way to flag those who may benefit from referral to specialist care well before the onset of manifestations like cardiovascular disease, cirrhosis, kidney failure, or HFpEF. In that sense, it supports a proactive rather than reactive management, which is particularly valuable in primary care.
Thank you. So I really hope that this would be used as a tool. And the new staging system also differs from the traditional metabolic syndrome criteria. Could you walk us through the key distinctions and also why is it important to identify patients who are at stage 1?
You're right to highlight stage 1. It essentially builds on the traditional metabolic syndrome criteria, but importantly includes insulin resistance as a defining component for the first time. To clarify, while insulin resistance is central to the pathophysiology of metabolic syndrome, it is actually not explicitly included in the diagnostic criteria. Identify people at stage 1 is crucial because this is the time where we can contrast individual risk factors before any functional organ damage occurs. However, I'd argue that detecting stage 2 is even more rewarding. It flags the onset of subclinical or early organ dysfunction, giving clinicians the chance to act before the damage becomes irreversible. Whether that's subclinical atherosclerosis, asymptomatic diastolic dysfunction, early liver fibrosis, or kidney impairment.
I think that leads nicely to the area of public health and prevention. So the paper estimates that more than half of participants aged 40 to 69 in the UK Biobank database were in stage 1. And despite decades of promoting lifestyle changes, uptake of these lifestyle interventions still remain a challenge. How do we implement realistic and sustainable prevention strategies, in your opinion?
I mean, this is overwhelming. I remember being genuinely surprised the first time I saw how prevalent stage 1 is in this group. It underscores the scale of the problem. But we can't afford to be discouraged. This is exactly why we need to keep fighting this epidemic with persistence and clarity. Reinforcing lifestyle recommendations like increasing physical activity, reducing sitting time, and improving diet remains fundamental. The challenge is making these changes realistic and sustainable for people, and that requires consistency across primary care, public health messaging, and policies. Prevention won't stick unless it's supported at every level.
So speaking of stage 1, so the paper suggests that stage 1 is potentially reversible, which is promising. But wouldn't it be better if people didn't reach stage 1 in the first place? And given data showing that metabolically healthy individuals often don't progress, could this indicate that some current strategies are already working?
I mean, it is true that stage 1 is potentially reversible, although we have not formally tested this in the UK Biobank. But ideally, would prevent people from reaching that point in the first place. As for the idea that some individuals remain metabolically healthy over time, I think that's a message that needs to be approached with caution. In many data sets, so-called metabolically healthy people with obesity are typically younger. And what we're really observing is a temporary state. With aging, metabolic flexibility declines, and many of these persons eventually progress to metabolic dysfunction. So in many cases, they're not truly protected, they're just not there yet.
The paper also discusses the promise and the risk of GLP-1 receptor agonists, particularly the issue of muscle mass loss and unsupervised use. With their growing popularity, how can we improve education for both the patients and the healthcare professionals to ensure that these medications are used safely and effectively?
Regarding long-term safety, I think the data for GLP-1 receptor agonists is relatively solid. We've been using exenatide, a GLP-1 receptor agonist, since 2005 in the US and 2006 in the EU. So we have now almost 2 decades of real-world experience with this class. However, what remains uncertain is the long-term safety profile of dual and triple agonists. For example, those targeting additional pathways like GIP and glucagon receptors. These agents are still in early stages of clinical use, and we lack long-term longitudinal data. As for muscle loss, it's true that any caloric restriction, whether it comes from diet or pharmacological appetite suppression, leads to reduction in both fat and lean mass. That's a well-established physiological response. What's not clear to me is whether GLP-1 receptor agonists amplify this effect disproportionately. In other words, are they causing more muscle loss than would be expected from equivalent weight loss by other means? This is a critical question, especially for those already at risk for sarcopenia. In general, for these drugs to be safely used by healthcare providers, we need a twofold education strategy. For healthcare professionals, especially in primary care, there must be clearer guidance on patient selection, monitoring, and also integrating physical training and protein intake into the treatment plan. For people receiving these medications, we need to emphasize that incretins are not a standalone treatment. They must be combined with lifestyle changes to preserve lean mass and metabolic health. Ultimately, the message should be these drugs are powerful tools, but only when used with a structured long-term care strategy.
Thanks a lot. So I will zoom in on some diagnosis. So what biomarkers or clinical signs are most useful in staging systemic metabolic disease? And also, another question that in the UK Biobank, dyslipidemia was the second most common factor after overweight. How do lipid markers such as Lp(a), LDL cholesterol, they factor into the staging and risk assessment?
In stage 1, two of the most clinically practical markers are HOMA-IR, which reflects insulin resistance, and the waist-to-height ratio, which estimates visceral adiposity. An HOMA-IR greater than 2.5 is a commonly used threshold to define insulin resistance. Similarly, a waist-to-height ratio greater than 0.5 indicates excess visceral fat. For example, in someone like me who is 180 centimeters tall, the waist circumference should be ideally below 90 centimeters. These metrics are simple, accessible, and meaningful in early stage assessment. For stage 2, one of the tools introduced is the Fibrotic NASH Index, FNI. This estimates the risk of metabolic dysfunction-associated steatohepatitis MASH with associated fibrosis. It's a non-invasive score calculated using three routinely available clinical parameters: AST, a liver enzyme elevated in hepatocellular injury, HbA1c, reflecting long-term glycemic control, and HDL cholesterol. A value greater than 0.33 strongly suggests the presence of fibrotic MASH. What makes FNI particularly useful is accessibility in routine clinical practice. All components are usually part of a standard lab panels. And its potential role in identifying people at risk of fibrotic MASH without requiring imaging or liver biopsy. As for the second questions on lipoprotein, in the consensus staging system, we focus on atherogenic dyslipidemia, which is highly associated with hepatic steatosis. This includes triglycerides greater than 1.7 nanomole per liter, non-HDL cholesterol greater than 3.4 nanomole per liter, apolipoprotein B greater than 1.8 gram per liter. This pattern reflects the overproduction of the LDL particles by the liver, which drives an increase in triglyceride-rich lipoprotein, remnants, and often elevated LDL cholesterol. That is typical of mixed hyperlipidemia seen in metabolic dysfunction. As for Lp(a), it was not included in the staging framework because it is not mechanistically linked to metabolic dysfunction. However, it remains a relevant independent marker of cardiovascular risk and should still be integrated in the overall CVD risk in clinical practice.
So looking ahead, the consensus paper highlights the future role of polygenic risk score. With growing awareness about genetic privacy issues, do you see this as a feasible approach, especially in low-risk populations?
The consensus does emphasize the potential utility of polygenic risk scores in the future, particularly for early identification of at-risk individuals for metabolic dysfunction. However, we need clear thresholds and transparent policies on data privacy. In low-risk populations, the clinical utility of polygenic risk scores remains limited for now. The predictive power of current scores is still modest, and most have been developed in European ancestry cohorts, which limits their use in other ethnic groups. That said, the concept is clinically intuitive. Genetic risk is present from birth, so earlier knowledge could theoretically guide lifelong prevention strategies, especially if integrated with environmental and lifestyle risk profiling.
Globally, how generalizable is this staging system? What do we know about the burden of SMD in non-European populations?
At this point, the staging system has not been validated across diverse populations. Most of the current data reflects people of European ancestry, so we must be cautious in assuming it applies globally. The next critical step is to evaluate the organ-specific consequences associated with each stage and to quantify both the risk of progression and the potential of regression across stages. Just as importantly, we need to examine the applicability and performance of the staging systems in non-European ethnic groups, where baseline metabolic profiles and clinical trajectories may be different. Only through this kind of validation can we ensure that the staging framework is universal and clinically useful in a global health setting.
Now for the parts that we are really excited to share behind the scenes of building the consensus statement. We would want to get some more insights from you, and I'm sure you'll be more than happy to share that with us.
This process took 2 years. And for our listeners who have never been involved in such a process, what is it really like? And were there a lot of debate or disagreements as in what to include in this statement or what not to include? And can you tell us how you navigated this through and how did it work?
Sure. The typical time frame for a consensus paper is 1 year. This took 2 years. I have to say it was my first consensus paper, and I was also chair. So I cannot relate to what happened before. The time frame is right, took twice as long. And the main reason was that this was such like a huge area, including all the organs. And there were also all these other consensus papers that I mentioned before, the Lancet Commission paper on obesity, the cardiorenal consensus, they were coming when we were just starting. So what to do to make something that is a little bit more original, not that someone has done. So it was a long journey. Regarding discussion, yes, there was discussion. And the way that we chair handled it was just to put it as in a democracy. We just voted, on what the people wanted to make a statement on. I mean, this is the consensus about. So what most of the experts think, it's a consensus statement.
For early career state scientists, if you have one piece of advice to give them while being part of a consensus statement, what would that be? Like, what are some challenges or lessons that they can learn from?
I think someone being part of a consensus paper needs to feel the responsibility that you're doing something that a lot of people will follow. And that's actually something that really it was in the back of my mind all the time. So the question I had, like, what other colleagues will say about it? Will they agree on it? Is this like too much or too little? So I think the responsibility to do something that probably change clinical practice is the most important thing to bear in mind.
Prof. Stefano Romeo, thank you so much for your time and insight. It's been a privilege and an honor to dive into this work with you. So thank you very much, and thanks for your time.
Absolutely, my pleasure.
Hello, I'm Helen Goldfish, and I'm a Senior Research Fellow from the Kheirkhah Cardiovascular Institute at UCL in London. My work focuses on cardiovascular science, especially atherosclerosis and how it affects the heart. I'm really passionate about bridging basic science with clinical impact, and I've also been active in young scientist committees, which has actually been a great way to connect with the research community. I'm happy to be here.
Hi, and I'm Ralph Komiache. I'm currently a Senior Research Fellow based at the University of Nottingham with the Centre for Academic Primary Care. My research uses large electronic health records to identify individuals that might be at greater risk of adverse outcomes and try to find which interventions might be most appropriate for these unique patient population or patients group. Thanks for having me.
Sure. So you were both directly involved in the development of this consensus statement as EAS Young Fellows, and maybe other early career scientists would like to continue in a similar way. So how did you get involved in this consensus statement?
So we first heard about this opportunity during one of the Young Fellows program presentations. And then not long after that, we both got an email asking if we'd be interested in joining the process as observers. It wasn't something we were expecting, but it was such an exciting invitation. We knew right away this was going to be a great learning experience, and it felt like a chance to be a part of something much bigger than our day-to-day research.
Yes, as rightly said, I also got an email from, we hadn't applied for it. I hadn't planned to be part of any consensus group, but I thought it was a great opportunity to do something that you would always dream to be involved as an early career researcher. And there was a big overlap with the research that I do. So I thought that was a great opportunity to be involved and see what actually goes into developing a consensus paper and what happens behind the scene. So that's how we got involved.
So now talking about that, let's take a step behind the scenes. So what is the process like? We can, for example, start by talking about the different steps from being invited to carrying out your specific roles.
What it involved was we had an email which invited us whether we were interested. We expressed interest in that, and then there was a bit of administrative process that went on, and then we were invited to the very first meeting. For us, we had to join virtually, which was fine because we still felt very much involved and we felt we were actually part of the team. Most of the senior members were actually there in person, but I must also highlight that some of the senior members weren't there in person. They also joined virtually because of time differences and people joining from different parts of the world. So it was interesting to be in that space, and though it felt a bit overwhelming, it was exciting to then have the opportunity to make inputs into what was being discussed and what was being developed at the time.
Exactly. And to add to that, what made it even more rewarding was that later on in the process, we were asked to review a draft of the manuscript and share our comments. It was actually a very encouraging gesture. It showed that even though we were early career scientists, our perspectives did matter. Getting to read through the full draft, reflect on it, and offer feedback gave the whole experience a real sense of involvement. We weren't just passive observers, we were actually part of the conversation, which was great.
Wow, that sounds very exciting. So now can you share something that you learned from this process, or a surprising challenge, a memorable moment, something remarkable?
For me, I think what stood out the most was seeing how a group of scientists from different backgrounds could take on such a complex issue and bring structure to it in such a way that was actually usable, like the 3-stage framework they developed. It didn't oversimplify the science, but it created a shared language for understanding how metabolic disorders progress. That kind of clarity is so valuable, especially when you're working across disciplines, I think.
Yeah, and I think I would want to add, it was interesting in terms of like the level of discussion that goes on and the rigor with which they interrogate every evidence that's available. And you would also realize that even though people are experts in their field, they have a nice way of being able to interrogate the evidence in a very respectful and accommodating and very tolerant way. And that was exciting to see. And also, one thing I would want to highlight is how they're very much conscious about the wording or the choice of words that they use to describe or to actually label various like stages. So you'd realize there's been a shift from the terminology from cardiometabolic disorders to system metabolic disorders. And there was a lot of discussion going on just to come up with the appropriate word. And for that, it was quite impressive and nice to see how this is done at such a level. And one thing I wanted to highlight was the level of commitment and dedication, because these are people who are in different parts of the world. And for some people, they were joining at like 2 a.m. And I had to ask myself, would I really find myself being awake at 2 a.m. just to make sure that like I work on a consensus paper and like be that dedicated and committed to developing such like a statement. So it was commendable to see that, and it was encouraging as an early career researcher to see the level of like commitment and dedication that goes into the development of this.
Yeah, but it is important to also commit to this kind of important work. And also looking ahead, do you think that this experience will have an impact on your career? Could you do this again at 2 a.m., for example?
I definitely would. I think being part of this process gave me such much better understanding of how our work in the lab can actually connect to broader clinical questions. Sometimes when you're deep into bench research, it can feel a bit disconnected from the bigger picture. But this experience reminded me that what we do feeds into something that ultimately helps patients, and that's incredibly motivating.
Yeah, I think I would definitely would want an opportunity to be a part of another one, probably with the knowledge and experience that I've gained from this, be able to contribute a lot more to it. It also gave an opportunity to see how collaboration is done, like in a very nice and like supportive way, where they realize they have a gap in the evidence or a bit of work that needs to be done. Those discussions about collaborating, finding out the appropriate team that has the appropriate data to be able to do the most appropriate kind of analysis to support that. So the learning was great, and I would definitely love to be involved in another one or contribute to another consensus paper development. So thank you.
Yeah, this was very insightful, and thank you for sharing your experiences with us and representing the EAS Young Fellows so brilliantly in this consensus paper. And thanks to all our listeners for joining us for this special episode. We hope it gave you a deeper understanding of systemic metabolic disorders and how this new staging system might shape the future of prevention and care. And who knows, maybe it even inspired some of you to get involved in the next consensus paper yourselves. Until then, don't forget to leave us your comments and suggestions, and stay tuned for the next Athero Talk podcast episode. And huge thank you to Rafa and Pelin.
Thank you for
Thanks for
having
having us.
us.